Hey everybody, welcome back to the Pre-Hospital Paradigm Podcast. We have a special December episode for you. Big super cut of the best of all 24 episodes of our first 2 years. So hope you enjoy. All right, guys. Episode 1 was our CPAP episode. Was the pilot program and the first kick off the entire series. So it was the 4 of us, and we talked for like 2 hours on CPAP. I thought it was pretty good for a bunch of guys that didn't know what they were doing.
I still don't know what I'm doing.
Yeah, that's right. It's rough to go back and watch where we started.
We're all standing there.
Yeah, how uncomfortable we were, but
the table was different.
Yeah, everything was different,
loud,
right? Yeah. So, but anyway, here's us talking about the benefits of CPAP.
Right? We're trying to avoid that. So be eager to utilize this product to try to avoid innovation. We don't want the patient to get intubated and then they go to the ICU, right? And then the risk for ventilator pneumonia goes up, increases. And it's just we go down that sepsis path then, and that's not good for them.
To put numbers to that, by putting a patient on CPAP, you're going to reduce the risk of intubation by 65%.
Early CPAP.
Early CPAP, right? You're going to reduce if they end up staying in the hospital, which if you're putting on CPAP they likely are. You're going to reduce their stay by about 3.5 days total.
So this is one thing that I don't like, and I've heard a bunch and I've seen. I've got somebody on CPAP. They've done beautiful for me, and they're tolerating it well. Their numbers have all come up. They've relaxed, gotten rid of the carpal tunnel syndrome. We're there. Their numbers look great. I get him at the bedside of the ER. The nurse takes it off.
Yeah.
And I walk back in after I've got done getting my signatures, and I hear respiratory being paged to the ER. I hear code to the ER, and it's like, what happened? Well, now they're intubating this patient. Why can't we have this better handoff care where I go to the ER and I say, look, I fixed them. Keep fixing them. But instead they rip this thing off, and I see them on a cannula. Well, their stats were 100%.
Yep.
They don't need it.
Everybody looks good delivered on CPAP.
Of course how do we break that chain of horrible chain of command?
I think a lot of that is on the phone call, and that is on the medic, but it's
that's
also
on us.
or the EMT.
That's a lot on
us. And that, I agree with you.
It's a lot on us.
It's bad hand of care.
Yeah, look, you don't understand. This patient was an absolute mess when I got him.
He looks great now.
Yeah.
Because
this is way better.
I fixed it, yes.
You need to listen to me. Right.
Yeah, it's hard to paint that bad picture when they look great, right? Because we utilize the tools.
The numbers are great.
But also I think this is where pushing that nitro comes into play too for us. We can help this a lot. And we'll go into that, I'm sure, a little bit later. But for now, how do I hand off that care to say, hey, you need to continue on this treatment path I've done? This is why. It's scary.
So I think you have to front load it. I think it starts with your call into the ER. My personal opinion. I think it starts with your call into the ER. Hey, I'm X squad bringing you a patient that's on CPAP. I need you to page respiratory now, right? So when you walk in, then hopefully the ER physician hears that, knows that, or you got a good charge nurse that says, okay, so when you walk in and we slide them over to the bed, and then respiratory's there, right? And I see the biggest success from that standpoint because they're coming right off of our CPAP, and then they're either going right onto a BiPAP, or they're going right onto a CPAP again, and the respiratory therapist is there understanding, okay, they did this, they look great, I need to maintain this. And usually, I've never really had an ER physician go against that, or say, oh, I don't want respiratory, go back, right? So I think that helps the continuation of care is trying to front load the conversation, just pushing it on the phone. I'm requesting respiratory when I arrive. It gets them down because, how far away is that respiratory department from the ER too?
I like what you said
they're
about
doing 100 other things, right?
Yeah, about the physician usually isn't our issue. It really isn't. And one thing that I want to try to bridge when I teach the medic class, when I do CEs, is we cannot be afraid as a paramedic, as a basic EMT, as an intermediate EMT,
as a patient advocate
of talking to the physicians.
Yeah.
A lot of times I see that the paramedic or the basic will walk in and be like, talk to the nurse just fine, but when the physician comes in,
I'm going to give my report like this.
I'm going to give my report like this and walk away. What are you afraid of?
I did things.
I'm not particularly afraid of Dr. Hill. But if I express, but if I express to him patient advocacy, and I say, this is why I did this, I think you're going to have a better outcome. But we need to stop not having this bridge between Garlisi says it best, Dr. Garlisi, we're physician extenders. Right. And that's more what's happening with the paramedicine culture. And we need to be able to talk to our physicians as peers and say, this is what I did, here's my continuum of care, because that's exactly what it is. But if we're not doing that, if I'm giving my hand off to the paramedic there, and I'm, hey, buddy, I haven't seen you in a couple of days. Oh, here's my patient. There they are. You got my squad phone report, right? Cool, I'm out. That's not
totally inadequate.
That is totally inadequate. We need to be doing better and so do better, man.
Let's talk about this. First, I think report's going to help. If you say, hey, I need respiratory at bedside, that's one thing. So I have so many thoughts right now. Between these two devices is with the yellow box. That's a device that belongs to the squad. You guys have to hang around.
Yeah, we're getting it. I'm taking it. And if I don't, my chief will tell me.
Yes. Not only your
You're
chief,
afraid
I'm sure
of
other guys.
He's going to chase you down. He's the guy to be scared of.
So now you're leaving equipment with us that you guys know how to retrieve. Both of these devices I can plug into the wall and just go, and I can leave patients on both these devices. The benefit of the totally disposable system is you give a report, I can leave this patient on this device, and you guys can walk away and don't have to wait to retrieve your yellow box, right?
All right, episode 2. This featured Dr. Spanner. He joined us, and we talked about a bunch of drugs, but we specifically zoned in on ketamine. Yeah, ketamine, and this was us kind of starting to come into our own. It was still early and a little bit gritty. We were still standing. Yeah. It was a little bit gritty, but we had an absolute blast with Dr. Spanner, and I think that was some of those shorts from that episode is some of the most watched.
Yeah, I think he did a great job with that. One of my standouts from that episode is if you wish you had a taser to help control your patient, that's what ketamine's for, and I think that's a great learning point from this episode.
So hey, here's Dr. Spanner talking about medication-assisted, specifically ketamine-assisted airways. So for airway, I think there is in that patent column, patent airway column, if you need chemical assistance in taking their airway. I guess let's start with who do we need chemical assistance? If this patient's already obtunded, do they need ketamine? Because somebody can literally read that column.
If they have a gag reflex? Sure. If they have need for sedation, frequently they may need paralysis. And when they do head-to-head studies on chemical-assisted intubation versus rapid sequence intubation, at least in the emergency departments, the rapid sequence intubation wins every time. I mean, by far. When you're in the emergency pre-hospital environment, there are squads that have chemical assist, and there are squads that have RSI. And the chemical-assisted intubations are not as successful as RSI, but they're quite helpful. And our two drugs that we have are either a benzodiazepine for chemical assist. You're not going to get this kind of response fast enough with Ativan, but certainly with Versed you will. Sure. But Versed comes with untoward effects of hypotension and respiratory depression, which is really problematic in a head-injured patient. For example, you never want them to be hypoxic, less than 93% for more than a minute, and you don't want them to be hypotensive, less than 90 for more than 2 minutes. Unfortunately, a drug like Versed can cause both.
Help that along.
Whereas ketamine is not going to do that and may raise the blood pressure.
Actually support, yeah.
And certainly bronchodilate and give you the advantage of hopefully not getting hypoxic. So it is a phenomenal drug for chemical-assisted intubation. The dose is very straightforward, 1 to 2 milligrams per kilogram with at least 100 milligrams, because we don't want to be in that zone where they may be acting bizarre between 30 and 100 milligrams. Some people refer to it as the K-hole. That never really stuck with me. Just sounds weird.
So if I do that and I use that, do I still need to just go ahead and truck around with my succinylcholine or etomidate, or am I just good there?
Okay, so really good question. The ketamine for sedation, for chemical assisted, is going to last about 15 minutes. The advantage of ketamine is you can then give half the original dose and get them back over that threshold when they start coming around. Or you can do what a lot of people recommend, and that is use your Ativan if you're carrying Ativan, because you're not going to get that hypotensive effect that you'll get with the Versed. Or use small doses of Versed. 2.5 milligrams of Versed, you are never going to see that hypotensive event. You're never going to see that respiratory depression with a 2.5 milligram adult dose of Versed. And that'll buy you 20 more minutes of sedation. So that's just another option. So you can either give more ketamine or add a benzodiazepine. For me, I think adding the benzodiazepine avoids the emergence that some people get with ketamine. So if I'm giving them the 1 to 2 milligrams per kilogram, at least 100 milligrams IV, no more than 200 milligrams IV. So basically, you have your 500 milligrams and 5 cc's. You're basically going to give them 1 to 2 cc's. You don't have to dilute anything. You just drop 1 to 2 cc's. You inject the appropriate amount. The patient should be very sedated, or what we call disassociated, within 1 to 2 minutes. You then intubate the patient, and once you get everything set up, your pulse ox is on, your capnography is, side port is on, you're managing a head injured patient, keeping the capnography at 35 because that's what you're looking for, making sure your pulse ox stays above 93, monitoring the blood pressure, and going obviously to a trauma center if you've got that kind of a significant head injury. The next move is sedate that patient. 2.5 milligrams of Versed if you have it, 1 to 2 milligrams of Ativan if you have it, is a nice gentle way to keep that patient sedate and avoid any emergence.
But I don't necessarily have to jump to a paralytic.
No, the paralytic's only use in the field for squads that have rapid sequence intubation is placement of the tube so that the cords are paralyzed and you're controlling the situation.
And I know a few times that I've used ketamine for intubation, I haven't needed a paralytic. The ketamine itself.
Do you carry a paralytic on your squad?
We do not yet, but I wouldn't have needed it. It worked.
Okay, the reason I'm saying that is I'd like to maybe be more definitive on that. If I have ketamine and a paralytic, I don't want to, because every time you try intubation, you're increasing the risk to that patient. Because even during sedation or disassociation, there's going to be a drop in the pulse ox. That's why you have to have your pulse ox hyperoxygenated before you make your attempt. Whether you're using it with a 15-liter nasal cannula transiently for the intubation, or you're bagging that patient's pulse ox up. Once you go for the intubation, that brief period of time is going to drop the pulse ox, and then it's going to take more than a minute to get that above where you need to be. So, to be very specific, if you have RSI capabilities and you've been trained appropriately in it and you're getting checked quarterly, I don't want to get into the whole thing, but if that's how it works, do the RSI. You're going to have a more successful attempt, and I don't want you to get in the habit of thinking, you know what, I don't want to paralyze them, I'm just going to sedate them or disassociate them, and I'll probably get it. If you are trained as an RSI provider, you need to do the RSI.
And the flip. Episode 3. This is near and dear to Dr. Hill. So this featured Chris Fredmonsky and Tyler Carlton. Chris was the paramedic that went into cardiac arrest.
I literally bored him to death.
Yeah, bored him to death during your lecture. He arrested during your CE lecture, and that was a great and interesting episode in hearing it from a first-person point of view, from the perspective of a care provider himself, right?
Well, and listening to him talk, and I've heard him talk a lot about that experience, is the first thing he remembers is he hears a BVM and he recognizes that sound, and then he feels the pressure in the back of his throat from the airways. So
it just gives me goosebumps.
Sure. That's wild.
So here's Chris talking about his story on that day.
Had you felt okay? Was there any warning signs?
No, I mean the normal fatigue for working multiple jobs.
You mean you work multiple jobs in EMS?
I know, it's kind of crazy to think that, but it does happen occasionally to some of us.
All of us.
The Hollywood pay that they pay us just doesn't always cut it.
Comes a
Lavish
few dollars
lifestyle
short.
you have to maintain in front of everybody. I mean,
Maintain a particular
yes, I
lifestyle.
mean, just having the posse around you all the time, it's not cheap. So yes, I work another part-time department. Usually work 12-hour days there. Work
Sure.
my 24th Streetsboro. Then on my day off, I do stuff on the side and keep busy as with all of us.
All of us, yeah.
So it's sun up to sundown sort of thing.
Felt generally well that day?
Yeah, I really had no complaints. My general fatigue, which is normal. My wife did say afterward that I looked very tired that morning when I left for work, and she was like, we'd had a busy weekend, had a couple things, family events and that, and she just said I looked really tired going to work that morning.
And this was a Monday? This was a
Monday
Monday?
morning,
This was a
January
Monday.
9th.
And
Got to work like normal.
had you worked a second job over the weekend? Or
No,
you actually you had a whole weekend off.
I had 2 days off.
We call that a golden weekend. in
Oh,
medicine.
it was nice.
You were exhausted from not working.
Exactly. But yeah, went in, normal morning, had breakfast with the crew, went out, did our truck checks, normal morning cleaning. We had our CE coming up we wanted to get ready for. I remember the doc getting there. I remember coming into the room, sitting down. There was an EMT student riding with us that day. He introduced himself, and I was like, I go, I think I graduated with your mother. And he's like, yeah, my mother. So I mean, it's like, small town Streetsboro.
Right.
There's a connection there. I can remember him introducing himself and us talking briefly. And then I don't remember any of the lecture.
That's fair.
So I apologize for that, but I do tell everyone that, everybody's like, oh my gosh, did the doc bore you to death? Whatever. And I'm just like, the doc saved my life. He gives a killer lecture there. You got to go, go see one of his lectures.
But for what it's worth, there has been absolutely no lack of harassing him as soon as we found out you were okay.
Free pacemaker with every CE.
I haven't seen the bill yet for
Hey,
this,
that was
so.
my line. I get credit for that.
But yeah, no chest pain, no shortness of breath, no complaints I can say that day that I remember anyways.
Yeah. And immediately before the event, just nothing.
No, I don't even remember. Like I said, we were over an hour into the lecture, weren't we?
We were at 2 hours.
Yeah.
I was literally doing the last one.
Always the last.
It's always that one, just one more, guys. So just remember when somebody says that, be like, no, maybe we shouldn't do just one more.
If he says it, definitely. No more. Where were you physically to Chris when it happened?
So I think we had a full shift since Streetsboro's a combo department. You have part-timers and full-timers.
Full-timers, yep.
And all the recliners were taken, so I grabbed a chair from the table and I sat like between two recliners.
Yeah.
And the other guy was back on the breakfast counter.
Breakfast counter, yeah.
Yeah, breakfast counter. He was sitting there next to him. So Chris is at the end of the table. Other guys at the end, counter. I don't know if I'm allowed to use names or not in here. That's going to be, if people are uncomfortable with that.
Dude.
The other dude.
The other dude or dudette was that?
Firefighter 1.
And then there was I right there.
Yeah.
And then it's here a thud. Someone's getting into a tussle, in a fight.
Yeah.
You look around, you hear, dude, you all right? You look around, he's on face down on the floor.
And you were in a recliner or you were sitting in a...
No. So, I specifically, whenever we have CE or anything, after doing this for so many years, I know not to sit in a recliner because I may nod off at any
You're
time.
going to take a nap.
period. So I sit at the end of the table, sit upright, try and, maintain and watch everything.
Right. Pretend.
Yeah, because I know if I sit in a recliner...
It's lights out.
Yeah.
Fair
It's
enough.
gonna
That's
happen.
for all of us, right?
So it's probably good I didn't because I may have just nodded off or this may have happened and they just might have been like, oh, hey, Freddie's sleeping.
Hey,
somebody go wake him up.
Yeah, and
All right, we roll into episode 4, which was toxicology. We had, for the first time, one of numerous visits, I think 3 total, was Dr. Jordan Singer, and he was talking about toxicology. And I know you guys... You guys are a little stressed on that.
My mind was blown.
Watch it 2 or
beyond.
3 times, and then you know what to Google afterwards.
Yes, he is definitely an expert in toxicology,
he came,
hands down.
He came heavy with the knowledge on this episode. So here's Dr. Singer talking about specifically aspirin toxicology.
Benzos and bicarb.
Aspirin
aspirin overdoses, and I guess we first got to differentiate. We're talking about acetylsalicylic acid here, we are not talking about Tylenol.
Right.
These are not the same thing.
Right. Despite many of our patients kind of using them synonymously,
Correct.
aspirin is a type of NSAID, but it works differently than all the other NSAIDs. So if you overdose on basically Motrin or Aleve or any of those things, not a problem. You overdose on aspirin, big deal, and that's why we're talking about it specifically.
And acid is in the name, so do I have a lot of acid-related problems?
Yeah, so it does cause an acidosis, but the reason that we really worry about it is because when aspirin goes into the brain, it does all the damage. And so when aspirin's in the blood or the rest of the body, little concern. When it crosses the blood-brain barrier, it causes an issue. And it can only cross the blood-brain barrier if it has no charge. And so when the pH is really, really, really high or alkalotic, it will have a charge. And so it'll get stuck in the blood, your body will pee it out, you're fine. But if your pH gets low, the proton will bind to it, it'll lose its charge, go right into the brain and wreak havoc. And what it does in the brain is it actually breaks down the electron transport chain and prevents, it's an uncoupling agent, which means it makes it so your body cannot make energy from glucose effectively, and it just releases heat. And the issue is now your brain gets no energy, and your brain uses tons of energy, and the net effect is you have injury to the brain, and you seize, and then you spiral and die. And so that's the goal of everything we do, is to make the pH of the blood high so we can trap aspirin in the blood and save the brain and save the patient. And that's really what we're doing.
And we're not talking about a daily 81 milligrams.
No,
How much are you talking?
so it actually isn't that much, which is scary. So I think it's 4 to 8 grams of aspirin in a day is toxic, and when we're giving 324 of aspirin to somebody who's having chest pain, so we're talking 12 to 20 full dose aspirin tablets is all it takes to be toxic.
Wow.
People are taking a lot more, and it's incredibly toxic. But the thing is, kids are smaller, so a little baby gets their hands on a full dose aspirin. Like 3 full dose
But they're
aspirins are
pretty. They
enough
have
to
little
kill.
pink hearts on them.
Which is why it's terrifying. Yeah, so it does not take much to be a problem. And another thing is there's salicylic acid in oil of wintergreen, and so oil of wintergreen is it's the flavor. It's wintergreen flavor, but you can get concentrated oil of it to use it to kind of maybe you can flavor things, but you can also use it for the whatever creates the scent. You guys know what I'm talking about?
Yes.
Like aromatherapy.
Yeah, one of those things. But you can buy concentrated versions of it, which basically like 1.5 cc's is enough to kill you. Like a tiny little bit has so much aspirin, or not, salicylic acid in it that it could potentially kill you. So that's, a kid may smell it and drink it. It does not take much.
Now, when
which
we
is
were teaching the
terrifying.
lecture, that came up, and then it was just like you saw everybody's phone come out, and then Google hit. You know, so we got to
like,
that, 'cause
what
that
is
was Dr. Singer put that in his lecture, and we get to that, and everybody's just like astonished. And I remember we stopped. Everybody Googled it because it was just like
A crazy amount.
Can I believe what this guy's saying at the moment? Like, was this like a random slide? Like, and then everybody read it. Wow, it's astonishing. There was just that little amount. That small volume of it is dangerous.
Yeah. And this is over the counter. I mean, this is an over the counter drug, because if you take it normally, completely safe. You take too much, big problem, as we were just talking about.
Well, geez, up until recently, anybody the age of like 65 is just put on it, and it's, wow.
It's crazy. Small amount.
So, goals here.
The goal is to, as I mentioned before, is to keep it out of the brain. And so what we do is we're going to give people sodium bicarb, but not for the sodium component. We're actually giving it for the bicarb. And the reason that it'll raise the pH in somebody who's awake and breathing is because you give it to them and they will blow off the extra CO2 and their pH will go up. But if they're in cardiac arrest and you're bagging them, it's a closed system. You can't bag them any more than you already are for that pH, so you can't fix it. But in an open system with an awake person, you can actually get their pH to get significantly higher.
That's important.
Which is the goal.
They have to be breathing, right? Because you're taking that bicarbonate is taking acid and turning it into
CO2 and
water and CO2. It's got to have some place to go.
Exactly. And so in this case, we would want you to give the same dose you would give for sodium channel toxicity, like one amp of bicarb or 2 if you have it.
So inherently, this patient should be tachypnic when I get them.
Correct, for multiple reasons.
What if they're not?
And that brings up a good point. So they should be tachypnic because they're acidotic from the aspirin. They should be breathing fast. And aspirin goes directly to the brainstem and just tells you to breathe faster. So so a lot of these people are already alkalotic, which is semi-treating themselves. Sure. But if they get tired or they get really altered, they may not breathe as much, or worst case, they become apneic. And then their pH is going to plummet, and all that aspirin goes into the brain and makes things worse. And so in this case, you would have to take their airway.
Normal is bad.
Yeah, so you want them to be breathing fast. So if they're breathing normal or hypoventilating, that's super dangerous. And you potentially have to take their airway, which is also very dangerous, because if they're breathing a little bit, that's better than nothing. And if you are an RSI-capable EMS agency and you push a paralytic, even if you get that tube in world record speed, 20 seconds, their pH is still plummeting during that 20-second apneic period, and no one's really tubing within 20 seconds and bagging that quickly, so it's always a little bit longer. And because of that, we would even recommend giving some bicarb in advance to that. Right before you push the tube, give them some bicarb and try to see if you can get their pH just a little bit higher to buy you a couple extra seconds without aspirin going to the brain.
And Chevy, should we?
So episode 5, we were it was just the four of us back in the studio for a discussion about stroke, and I think we all bored each other to death. No.
Enjoy.
Yeah, right. Enjoy. Be bored with us. No. So yeah, we were back in the studio, the four of us, for a stroke episode, and here is Dr. Hill talking about the VAN assessment
And saving the penumbra.
The penumbra.
So we've got expressive aphasia, and essentially they're having difficulty either picking a word or coming up with a word. So it's speech. Expressive aphasia just means speech. Receptive aphasia means that they can't hear you so well. Their reception is not working. They can't understand you. And then global aphasia is just both don't work. Right. Essentially, it's really kind of simple. So. The hardest thing I think about this, and definitely better if you have family member there, or even sometimes that's the patient, is are the patients slurring their words? Especially if you don't know them, right? Sure. Because they could just slur their words, and that could be a baseline, or it could be from a prior stroke, or, hey, does your voice sound like your normal voice? Or family goes, is this their normal voice? Yes or no?
Yeah, I mean, my father-in-law is saying, his baseline speech was hard to understand, right? And if somebody, if a provider had come up on him,
never met him,
they would be looking like, no, that's okay.
Well, or we have that other thing too, where it's like we talk about blood sugar. I actually had one of our squads call me and interact with a patient, like slurring the words, and they're talking to him, but the patient, and it was an elderly woman, she was making perfect sense. A&O times 4 can answer all questions, no arm drift, and they're like, we're just not understand where you're getting your slurred speech from a little bit. She was a little, garbled, and it happened to be some vodka. So she had
4 fingers before you showed up.
She said it. She's like, I have some of these before I go to bed, helps me sleep. So we have to do a full assessment.
That's called Vacasia.
Just throwing it out there. You never know. Maybe a little alcohol on board.
Yeah, absolutely. You can have 2 things true at the same time. And then neglect is an interesting finding when you see it. For eyes, they're going to have forced gaze to one side. They're going to actually be ignoring one of their whole sides. For bad neglect, you can actually ask them, if I was having a stroke and you asked me, and if I'm looking at Scott, I would say I could see 2 people because I can see Scott and Caleb, and I don't even know Ray's here.
Ray's there, right?
So it's pretty profound and interesting finding, and not great for the patient, but definitely an interesting physical exam finding. So, anyways, if their vision is impaired in any way, they've got any sort of aphasia, or they have neglect, which is super bad, they're VAN positive, and raises our concern that they're going to have a large vessel occlusion. And the whole reason why we care about that is if they do have a large vessel occlusion and they're within the thrombolytic window, they're going to get their thrombolytic because that's the primary treatment for that. But it also opens up the ability of going for a thrombectomy. And Ray talked about those thrombectomy available, capable facilities, and then the comprehensive facilities can do it as well. But we have now, instead of the shortened time frame of a few hours to give the thrombolytics, we're now up to 24. So those wake-up strokes that we don't know, they went to bed normal at 9 o'clock, it's now 6. we can now possibly get them through to thrombectomy, go in there, mechanically pull out a clot, just like we do with heart attack and STEMIs, right? We go in there through the vessels, we just pull the clot out to then restore blood flow to the brain.
Yeah, that's why that CTA is so important, right?
Correct.
So they can, the hospital's going to do that non-contrast head CT, and if it's a large vessel, they can immediately follow up with a CTA and know exactly where that vessel is going to be blocked. So if you have to go to the mechanical thrombectomy point, then you're going to transfer to the thrombectomy capable hospital or comprehensive. They go in and remove that clot, and now it opens up such a larger window for those stroke patients to have that portion of the brain be reperfused. As
Correct.
before, it was, well, you're past the window. I can't give you that thrombolytic,
Yep.
right? I'm out of my time window, and then our options decrease. And Caleb, you talked about long term. Well, long term choices aren't very very good at that point.
Right.
Then they're just, this adds such another option for our patients.
Right.
All right, we'll roll into episode 6, which was tactical medicine. We had Dr. Tony Dare and Joe Sugar, our tech med lead for UH, and they were visiting. They were talking about all things. Boy, we talked about a bunch of stuff. This was, again, one of our early recordings. We were still standing.
Yeah.
And,
Actually, one of our most watched episodes.
It was
too,
our TAC Med, yeah.
with the TAC Med guys.
So here is Dr. Dare talking about some of the history of tactical medicine.
So, Dr. Dare, you kind of touched on the military influence in all of this. Obviously, anybody that's done an EMT or paramedic course, I mean, that's the first 4 pages of the book is, how we got here from a civilian side, basically born out of experiences from the military. Does that influence still exist? I mean, do the teams, do the practitioners of tactical medicine that I want to say do it more professionally, that are on a fixed team, are we taking information from the military or
absolutely?
Is that,
I mean, 100%. I mean, a lot of what we do really comes out of the military. For our direct threat protocol and for our gear and equipment and IFACs and those things that we'll talk about, all of that came out of the military, right? The military did a huge study and said, well, what is killing our soldiers, right? They looked through, a lot of, obviously with severe trauma, people have unsurvivable injuries and they die immediately.
It is what
right?
it is, right?
But what we really want to key in on, and what the military has learned to key in on, is what they call preventable deaths. What can you stop people from dying from?
Right.
And of that, they found that 2/3 of people that have what they call preventable deaths is hemorrhage. They just bleed to death. So that became their number one priority. In the direct threat, we want to stop hemorrhage. That can take a lot of different concepts. It can be pressure dressings, it can be quick clot, it can be gauze, it can be tourniquets, it can be all of those sort of things. Number 2, after that became tension pneumothorax. People die from tension pneumothorax. You have some period of time before that tension builds up and people die, you can intervene in that. So chest seals, needle decompression, that became our next thing. And then the third thing that people die from is basic airway.
Right.
They are unconscious, they can't protect their airway. Now that becomes a little tricky because we have a lot of ways to protect airways, right? We can intubate people, we can use supraglottic devices, we can use video laryngoscopy, we can do all of those sort of things. But you're in a direct threat environment.
In that context.
So you have to use what's realistic in your environment. So basic airway maneuvers, recovery positions, nasal or oropharyngeal airways, things like that you can do quickly in a direct threat environment has kind of become the third piece of medical care that we provide in a direct threat. And we do that because that's what the military learned through their studies. And things kind of then bleed into the civilian side of it. TXA, which we'll talk about probably at some point as well, is another issue that has come out of the military.
Yeah. Is it safe to say that if in a active shooter tactical direct threat environment, the provider is putting an artificial airway into the patient, BLS airway, during the extrication, that the survivability goes down basically in the order you presented them, right? So
absolutely,
hemorrhage, tension pneumothorax, and then airway.
100%.
Essentially, if
100%, for sure.
The more things we do, or the further we get down that list, the
less chance of survival.
Less chance of survival.
Absolutely.
All right, episode 7. This is Innovations in Resuscitation. This was, our guest on that was Dr. Capenza, Ross Capenza, and they're doing, under his medical direction, a few places, they're doing heads-up CPR, and this was really about heads-up CPR. Yeah.
Kind of like a cool pit stop stuff.
I really don't think we needed to be here for this episode. We probably could have just put him here, press play, and walk away, and we would have gotten the same episode. But regardless, here's Dr. Capenza talking about the first 5 minutes in his resuscitation paradigm.
Kind of before we came on the air, as far as talking about, we call it the first 5 minutes. So all we train in is the first 5 minutes over and over and over again. So our people get that muscle memory, and they get the muscle memory of, we even call it different tier level bags. So we call our first in bags to a full arrest are actually our Eligard airway bag, and then the monitor and suction and oxygen. And as you'll notice, we don't have Lucas there yet, and we also don't have a med bag there yet. And the reason why is, I think evidence-based medicine has shown, one, if we can get bystander CPR, that'd be fantastic.
Of course, right.
And then also even AEDs on the patient, which would be ultra fantastic. But once our people get there, really to focus on the CAB, so compressions, then airway breathing. And again, we all know, epinephrine now, that's its own podcast.
That's probably so.
Is epinephrine great, or is it the work of the devil, or you never know. Right. So the pendulum is swinging all over. I get better hearts, but I'm killing brain. So that's its own talk.
Every drug in there is up for debate.
Correct.
Yeah, or as I call it, medical holy water at that point. So,
not inappropriately.
So I tried to tell our people, hey, if you carry a med bag in, then you're going to be focused on the med bag.
Meds, of course, yeah.
And if you bring Lucas in, you're going to be focused on, I want Lucas right away, because they love Fire Medic Lucas. And I said, well, if you're going to do heads-up CPR, though, you have to do at least a round or two of rescue CPR. So again, Lucas isn't as critical. Obviously, in the initial part of a full arrest, epinephrine in the rest isn't as critical, even in asystole or PEA. They found by doing the heads-up CPR process, in fact, this is from Dr. Pepe, so he would have to comment on it, but he had made the comment that as much as defibrillation was to VFib, he likes rescue CPR, heads-up CPR to asystole. So he felt, what do we really have to offer these people in asystole? It's epi and treatable causes, which usually you can't find much anything.
Sure.
So he really, at least from his talks, really liked this whole process. So again, it's not just heads-up CPR, it's a bundle. Now, can I tell you what part of that bundle does it? No, because it's a bundle. I mean, you really do have to do rescue pump, rescue CPR, impedance threshold device, maximize flow. What angle am I going to put these people in? How am I going to do this? At what point do I deploy it? So there's a lot to that process.
Right.
So it's not just, I'm elevating the head.
That's always the troublesome part in any cardiac arrest.
Right.
Is understanding what roles any particular intervention plays. Right. And I think we found over and over and over, it's not one single thing. It's combination therapy that ultimately leads to the outcomes. Right.
And then I did look at our numbers. They're very, very small. And like I said, the nice thing is we do the quarterly meetings, so they get our numbers, but we can hear from other people throughout the country, and then load in their numbers to our numbers, et cetera. But I saw ours, like most people, probably around anywhere from 8 to 12% resuscitation, and all of a sudden we were getting, upper teens easily. Then all of a sudden, sometimes in a 6-month block, we would even get upwards of 28% resuscitation. Our numbers are small, so I would hit a stretch of asystole elderly patients where it probably isn't going to be working as great. But we definitely took us from 8 to 12%, peaked at about 28%. Now and we have all comers. I even brought my numbers, but we have all comers that a majority of our full arrests are still age 70 or greater.
Understandably so. Right?
Unfortunately for us, half of our full arrests are asystole, which I wish it was more VFib or
Of course.
a truly
Something you can fix.
viable,
You can work, right.
something I can work with. But even with that, we still are at anywhere between 18 to 28%, where before we were anywhere between 8 and 12%. And like I said, do I think it's just heads up CPR? Absolutely not. Absolutely not. It's the bundle.
Guys, episode 8 was, well, our leftovers. We had some questions and answers from a previous episode, and there was a bunch of stuff in there about steroids and dextrose, and we really kind of teased that out. It was just the 4 of us on this episode, and here's us kind of talking about maybe the underutilization of steroids and methylprednisolone specifically. So, all right, enjoy.
Yep.
We just don't feel like we get down to it. So
I think with Solumedrol, I'll open with we don't see the return on investment, right? So we were talking about drugs before this started, and we talk about D10, and we're able to correct that, and we see that return on investment. I think with Solumedrol, we don't see the return on investment in the ambulance, so we're like, it's down the tree. I'm not going to see the return. I don't see the patients change, but once we leave the patient in the emergency department, they're going to see the change, and then that could actually prevent, possible admission or a re-entry of severe shortness of breath. So I think that's what maybe some of the mindsets of providers are. Do you agree?
Probably, because you're not going to see it right away. Solumedrol is going to take hours to be effective.
peak, right?
Peak about 6, right? So you're not going to see it in the short time. Whether you have a long transport time, you're still not going to see it. However, what I tell my squads is that think of a typical patient call, shortness of breath. They've got COPD. We're going to give it for that shortness of breath and for the COPD exacerbation. They call you. It's been 3 days. They've tried everything they can at home. They've exhausted their resources. So they call you. You guys get there. You evaluate them. You give them a nebulizer. You start transporting. You get to the hospital in 20 minutes. And let's say that this is the perfect hospital visit. You get right in. You get to a bed. Get them tucked in. They're breathing okay. They're maybe on a little bit supplemental O2. We're finishing up a nebulizer. Then I get to go see them. And on a perfect visit, I'm going to be in there when you guys come in. I listen to your report. I evaluate the patient. I'm going to order Solumedrol. So now they've called you. You've had a 5-10 minute drive to get to the patient. You pick the patient up. You're there for 5 to 10 minutes. You transport me in 20 minutes. I get to see them. I evaluate them. That takes 5 to 10 minutes. I then go back to my computer. I put in the order.
Yep.
The order gets validated by pharmacy.
Yep.
Nurse then pulls the med and then administers the med. We're going to be at least an hour on past the initial 911 call that they're going to get that medication.
In best case scenario.
In best case. This is all based.
Right.
Looking at now, you guys, they call you, you get them, your evaluation time, transport time's the same, but now you're waiting on the wall for 3 hours. That's when you're actually going to see the improvement, is that 3 hour mark when you go to hand them off. And that's what we're seeing now in Northeastern Ohio, is these long wait times on the walls. But again, in the perfect order, we're at least an hour down the road before I get to see them. And honestly, if I can get them better and get them home, that's the whole plan. My goal and everyone's goal in the emergency department is to send people home. And I tell all my patients that, my goal is to send you home. If you have to stay and I want you to stay, you're pretty sick. You should probably be in the hospital. But you're not going to see that right away, that return on investment. However, what you are going to see is, though, if let's say that they get sick and tired of waiting at the hospital, then they go home and they haven't had their steroid yet, they're going to call you back again.
That's true.
Or you offer them to the waiting room, they don't have their steroid back. Yeah. And that's really what's going to cover them. And that steroid you give is going to cover for 24 hours. And that's all they need for the next 24 hours. If I get to see them, I'm going to write them prednisone for home. We're going to do a burst, and they're going to go home with their steroid, and that's what they're going to take in 24 hours. And we've talked before, Ray, that it's the nebulizers help, but it's really the steroids that decrease hospitalization. They decrease your hospital stay. They decrease the level of care you need in the hospital. It's really the steroids that do a lot of the heavy lifting.
Do the lift, yeah.
But like you said, I mean, there's a difference between an acute fix and a chronic fix, and people don't necessarily go towards it because it's not an acute fix. It doesn't happen instantly, so we don't see the benefit, but there's a tremendous benefit. And you hit it right on the head. I think Dr. Regina Yaski, last year did a pediatrics lecture, and she talked about that too. The pros and cons of giving it in the field versus in the ER for kids, and it was huge. Huge.
One of my favorite memes is, somebody holding up a Solumedrol vial, and they're like, "It's not going to work during transport," said the ambulance driver. Right? We are part of the global picture of patient care, and this isn't something that we can be skimping on. It is worth the time, and I think that just needs to be categorically said. Right? It's worth it. It's worth the time. Right? It's not. They're going to do it when they get to the hospital. They're going to do a lot of things. They may even redo a lot of things from a training. For a training perspective. That doesn't mean that there's not a place at a hospital.
Correct.
And you guys focused really on the breathing perspective of that. In my mind, I think
that's your most common call. The most common reason your guys can give steroids is going to be for
breathing. I don't disagree, but I think it's easier sell from the perspective of like an anaphylactic reaction, anaphylactic shock, where there's a much more marked difference in the their immune system's overactive. They've dumped all this histamine. They're bronchioconstricted. They're an absolute mess. We see the immediate action because we stab them with the relatively immediate action. We stab them with the epinephrine. Benadryl, oftentimes within our transport, we'll start seeing the benefits of that. But we haven't shut their immune system off, right? All we've done is blocked what the immune system has created, and we've blocked the critical thing that was trying to kill my patient as a result of the overactive immune system. That is a patient, you need to turn that off as soon as possible. We can't wait until you put your order set in, right? That extra hour, I think, is more critical in that patient